Hi, and welcome to the Anti-Waffle podcast with Em and Pixie.
Woohoo!
And together we'll try to talk about research without any gobbledygook. Each episode we'll be talking to a researcher who will discuss the work they're doing, looking at why this research is important and asking how did they get into this field. We hope that it will be informative and interesting and bring a bit of the academic world into the real world. Today we have Dr. Katelyn Smalley. She's a research fellow of person-centred care at the University of Plymouth. Again, thank you so much for being here today. Thank you.
Oh, no, thank you.
Do you want to start by telling us a bit about your research, please?
Sure. Yeah. So I am I'm a political economist by background, and I focus in health policy. So basically that means that I spend a lot of my time thinking about issues around the people getting access to healthcare and the quality of care that they receive, and making sure that access and quality of care is equitable across different populations of people.
So just to make sure I'm understanding it, so you're saying that you're just making sure that it's even, like everyone has equal access to the same quality of care.
Yeah. So I would say when you're thinking about kind of the health of a population, so in the UK we have the National Health Service, which means that care should theoretically be available to everyone at the point of service for free. But in practice, it's really difficult to make sure that that the system is kind of crafted in a way that everyone can get what they need when they need it. And so the idea is that not only is it difficult for people across different, across the geography that, people have different access to resources, communities have different access to resources. And that also means that people, that there are kind of social determinants of health, which means that different people have different need for healthcare as well. And so it's kind of a really challenging problem to figure out, okay, how can we make sure that whatever configuration of health services we have is responding to the needs of the people who are in the area where services are offered. So that's kind of what I mean by equity, is not that literally everyone gets the same thing, but that, that people get what they need when they need it. And that those needs can be different across different people.
Right. So I guess it's driven by funds. So we love the NHS, but the funding isn't always as what it needs to be. So is it making sure that if there's an area where there's a lot of elderly people, a higher amount of elderly people, then the funds go towards services that are for elderly people, that are most likely going to be the needs of elderly people. Is that what you mean?
Yeah, so that's definitely part of it. And I have a lot of colleagues who are more health economists who focus in that area especially. A lot of the work that I do is also thinking about when you are in a health service, when you are presenting with a health need, what is that experience like? And are you able to find the right service to meet your needs?
And how do you go about sort of gathering this data or getting the information to sort of help this research?
Yeah, so I'm what it's called a mixed methods researcher. And so that means that I take data from lots of different, in lots of different formats and in lots of different, from lots of different places. So for instance, what I did in my PhD was I did a combination of interviewing people. So I interviewed patients, clinicians, and policymakers, all, kind of similar questions around the same general topic, but getting different perspectives on the same issue. But then I also combined that with some electronic health record data, which we call it routinely collected data. So it's data that's collected for other purposes, but then we use that to learn things about a different question. So a lot of the things that I think about, I think that you can learn a lot about people's access to care and the quality of care that they're getting by looking at service use data. So, looking at, everyone who has asthma, how often are they going to the GP? How often are they going to A&E? Is there a correlation between the people who go to the GP less are showing up in A&E more? You can ask all kinds of different questions about the patterns of how people are using care, and combined with those other sources. So like surveys or interviews, focus groups, things like that. And you can put it all together and get a picture of, what is the experience of needing healthcare and then trying to get it. What is that like?
And who's funding it? who's behind it? Who wants it to happen? What you're doing, the research that you're doing, is it coming from the NHS? Is it coming from the government? Is it coming from sort of like charities or what?
Yeah, so my PhD research was funded by the NIHR, so the National Institute for Health Research, and I sit in a kind of, most of the stuff that NIHR does is not what I tend to do. So that's interesting. I've also done some work funded by charities. So I did a project recently where I was looking at how to encourage GPs to offer annual health checks for autistic people. And that was funded by the charity Autistica, which is a charity that is in large part founded and run by autistic people. And so they were interested they think that this is a good policy idea. And NHS England is interested in trying to roll this out. And they wanted to look at how do we maximize our chances for success. And so that's one. And then some of the work that I'm doing right now is kind of speculative. So I am employed by a university, but we haven't actually gotten funded for it yet. And so I'm doing the kind of preliminary work to figure out, okay, what is the right research question to be asking so that we can get this work funded by NIHR or by someone else.
What's the purpose of the research and who's going to be using the data?
Yeah, so obviously as an academic, part of my remit is to submit things to journals for publication. But I also think that my work, I see kind of having two audiences in the real world. One of them is patients or the public. I think that it's really important for us to, the NHS is a public resource. And so I think it's really important that we all kind of understand about what we're getting. And, if there are areas for improvement that, letting the public have the information that they could advocate for more, I think is really important. And then I think also policymakers themselves. So using the academic data and feeding that back in to saying, okay, this is the way that you can develop better policies that are responding to issues on the ground right now.
And do you do like case studies? Is there sort of like an example of an individual whose journey you've like followed or
That's a really interesting idea. The kind of work that I do is not so much with individual case studies. I think of case studies kind of more on a structural level, I guess. So yeah, the work that I was telling you about where I did interviews with a bunch of different people and then also looked at utilization data for tens of thousands of people in an area. I think of all of that as one case study of like one disease area. So yeah, kind of a case study of a group of policies that are affecting a group of people. But yeah, that would be interesting to follow a single person and like chart their journey. I'm sure that there are people who do that.
I'm sure there are, even if it's without permission or something. Everyone has
I hope not that.
So throughout your sort of research, has there ever been anything that you found really surprising that's sort of thrown up, any sort of results that have, like I say, really surprised you?
One of the things that has really surprised me, and as you can tell by my accent, I'm not from here originally. I'm from the US and I moved to the UK 5 years ago. And so as I've been doing this work on policies in the NHS, I've also been learning about the NHS and all of the ins and outs. And I think it's really struck me, and I don't know the extent to which the general public also realizes that the NHS is not one organization. it's a collection of like thousands of organizations. And so it's been really interesting to understand, you know, who's who and who does what, and the extent to which different NHS organizations do and don't talk to one another. And, you know, there's a whole kind of like very interesting political behind the scenes going on, which I find super interesting, especially because my background is kind of more in political science and things like that. So it's, yeah, kind of brought things full circle to it in a little bit.
Yeah, no, I agree. And you know, I've known the system all my life, and it still surprises me how much one department doesn't know what the other one's doing, and how much information isn't shared. It's like, but yeah, it's crazy.
Yeah, yeah.
I think that you could see so many. Just in using the system, you can see how many areas that money could be saved. Well, if I didn't have to fill in this form again and waste your time here because I filled it in 2 weeks ago in a different department, you know, it's just simple things like that. It's just, it is crazy.
Yeah, totally. Actually, I've been thinking a lot about that. You know, just like the duplication of effort sometimes is really shocking. And yeah, I mean, I think the other thing I was just talking about the other day is you know, we have this beautiful thing that is an NHS number, which means that you should be able to put a person's entire health record in one place, and that just doesn't exist. And yeah, it's interesting to think about, you know, what are the possibilities of, you know, we could provide so much better care to people if we had that kind of the ability to have the continuity, I guess.
Yeah, no, absolutely. No, it's just, and yeah. And whenever I'm filling in a form or logging into a site and they say, oh, do you have your NHS number? No. And it's like, well, and they say, okay, well, no, don't worry. And it's, well, maybe I should be worried, or maybe you should be worried. And maybe that should be what you're sort of like driving everything on. And it's, yeah, they're missing a lot of things, but we still love the NHS. It's our NHS.
Yeah, no, it's having said all of that, it's, you know, it's the fact that it exists and the fact that it's available to everyone. And, you know, we want it to stay that way.
Exactly. No, and we only want to fix it so it can stay longer, because, you know, it can't sustain itself with the wastage. It just can't keep sustaining itself with that unless it changes and fixes up. So, and we want it to sustain. We need it. We can't. Yeah, can't exist without it.
So you've talked about the sort of the case studies or the work you're doing at the moment, and what's your plans going forward then? Have you got other areas that you're looking into, or is that not on the agenda just at the moment?
So I have kind of two things in mind. One of which I'm working with colleagues at Plymouth, but then also at universities around the country to look at community mental health and trying to figure out ways that we can kind of conceptualize the mental health system, but then also develop a method for measuring the extent to which community mental health is meeting people's needs. So we're looking at some kind of cool new analytic methods to look at mental health data, but then also just really thinking about like what does it mean to have good, high quality mental health care, and what does access to good, high quality mental health care look like for people? So we have a great team that is, you know, some clinicians, some kind of social scientists like me, and then people with lived experience of mental health issues. So we have a really wide team that's come together to try and think through this really, really complex problem. And, you know, we're at the stage of really just thinking about like, how do we even describe this problem and think about it in a structured way so that we can come up with some answers to it. So that's been really interesting. I've been working on that for the last several months. And then another one that's kind of my own project is going back to my roots and back to, I'm also someone who I really like theory and thinking about, how do we think about the world, and how do we understand how people interact with one another. So I'm working on a project that is bringing together some theories from economics and social science and sociology and political science to understand how we end up with the person-centered care policies that we do, and how different, we call them stakeholder groups. So how do policymakers and patients and different clinicians and other people, how do they all kind of talk to one another and develop, how do we end up with the policies that we have, and then how are they implemented in the world? I don't know if that is a good, it's a very heady explanation, so I'm sorry.
No, I like that one. I like the sound of that one, because it sounds like you go in, like, looking at it historically. Well, how did we end up where we are now, so that we can think, well, how can we correct that to go forward? Is that right?
Yeah, I think so. And I think that the tendency in health policy or health services research, and it's understandable because the health service, it's happening all the time, so you need to make quick decisions. But I think we don't do enough of the stepping back and saying, like, okay, what have we done so far, and what has the effect of that been before we chase the next shiny object. And so this project is really trying to think of, okay, what are some patterns in the way that we have tried out new things, and what have we learned kind of from them as a whole, and what, in an effort.
When it comes down to the whole department issue of because there's so many different factors and factions and departments, and they're not talking to each other. So when someone has an issue in their section, then they will come up with a solution for the issue, but just looking at their section rather than thinking, well, how is this going to affect, the other departments down the line? And so, so it's about having this, looking at it from a more holistic, a bird's eye view of it, I guess, which, it's very exciting.
Yeah. And I think it's one of those problems that happens at multiple levels as well. So it's at the level that you were talking about, where the departments, it's almost like it's a cultural thing, because it replicates at like the individual level, but then also at the department level, and then also at the really broad, like national policymaking level, where, every 5 years we're going to revamp the entire structure of the NHS, and like you have new acronyms that you have to deal with, and the extent to which that is, we're actually revolutionizing things, or we're just changing the words that we use to describe them. I just find it really fascinating and interesting, like, what are we actually doing versus what do people think that we're doing when we make big changes like that. So that's kind of the driving force behind that project, which is still very early days.
Yeah, I can't even imagine where you'd start. So well done. Good luck.
I've started by reading Foucault.
Oh, that's brilliant. Please can tell us, how did you get to this area and this research?
Oh, a very winding road. Yeah, I'm one of those people that can never really decide what I want to do, because I'm interested in a lot of different stuff. And so I think I've ended up in this kind of area of health policy mostly because it was a way to bring together a lot of different things that I'm interested in. So at university, I studied political economy, and I was also pre-med, which is a very American idea, I guess, because you go to a medical school after going to university. But I wanted to keep myself open to that possibility. Honestly, so I've always been interested in politics and policy and government, and how big time decisions get made. But then also when I was in university, honestly, my interest in healthcare kind of stemmed from the fact that both of my grandparents, who I was very close to growing up, became ill at various points, and just getting that window into how health services actually play out on the ground. They, the kind of the structural stuff, but then also the like one-on-one relationships, and just like you were talking about, Pixie, the miscommunications or lack of communications between departments, things getting lost, people coming in and thinking that they were a different person, and all of these things kind of made me interested in the idea that there is a connection between the very high level stuff that's happening in government and the way things happen in people's everyday lives. So I got a job right after university in health policy doing exactly that. So I worked at the Medicare Payment Advisory Commission, which is a US government agency that looked at issues of payment, access, and quality in the US Medicare program, which is the program for older adults, which was the health insurer that was paying for my grandparents' healthcare. And so, yeah, it kind of brought together the personal and the professional in a way that I thought was kind of interesting, and I could make an impact doing that. And as I was there, got really very detailed procedural knowledge of how things work in the US. And then while I was there, I still felt like there was a disconnect between the very heady discussions around, okay, but how do we pay for things, and what are we incentivizing people to do or not do by making certain decisions? And there wasn't really that a very good understanding of what was happening on the ground. Like, how do these decisions play out in the real world, and how do they actually affect people? But yeah, so after that, I did go to med school. I lasted 10 weeks. I hated it. And then, went back to policy, but decided that I wanted to go back to graduate school. I wanted to keep working in health policy, but I wanted a different lens on the problem than the one that I had been exposed to before, which was very influenced by economics, and was very influenced by, kind of the US model of insurance-based healthcare. And lots of the conversation in US health policy is around, what are the right payment rates, and how do we encourage people to buy the right insurance plan? And are we sure that having healthcare coverage is really good for people or not? Like, kind of questions that, at least in this country, feel like a non-starter, obviously.
Crazy, isn't it?
Yeah. And so, so I came here and did my master's in health policy at LSE, and got exposed to not only the UK, but people across the world, lots of different healthcare, lots of different ways to organize healthcare, and all of which kind of start from the starting place of, we should provide as much healthcare as possible to as many people as possible, which I felt kind of opened me up to those more interesting questions of, okay, like, what is the quality of care, and what does that look like? And what does access mean when you don't have to worry about quibbling over how much people should pay for each individual service? So yeah, I came here for a one-year master's program, expecting to move back after a year. But then I stuck around for a PhD, and yeah, my PhD also was even further into that kind of, what are health services like? And I got really deep on the ground, a good understanding of like what it's like to be in the medical field, observing and talking to clinicians, and then working with patients. And now, yeah, I'm kind of taking one step back, and now I'm in the process of thinking about, okay, what does it all mean? And how can we take these learnings from the ground and feed it back into policy?
I think it's a good journey. It's what it feels like is like that you wanted to help, and so then you started like working at this level, and then thought, well, hang on, what's causing this level? And so you went up to, so I see, but wait, what's causing this level? What's prompting this? And then sort of like just going further,
it's kind of, I've been kind of ping-ponging back and forth between, okay, that's too far abstract. Okay, this is too far down to the ground. Okay. And I'm guessing I'll probably end up toggling between the two for the rest of my career.
Can you sum up why your research is so important to the public?
That when people think about politics and government, they tend to think about politicians and elections, but most of the work of government, of policy, happens by nameless, faceless bureaucrats. And the work that they do is often really good, but it's also really, really important. And the decisions that people make on those kind of lower down levels of government are the ones that have real impacts on people's lives. And, I focus on healthcare, but could equally focus on other areas of policy, the environment, education, anything else like that. I think that it holds in those other areas too. But I think it's really important to understand what happens when the rubber meets the road in terms of policy. So, the decisions get made and then, they get put out into the world, and then people have to implement those policies, and understanding what those decisions are and why, and then how they get translated into action, I think is just really important. And we don't do a great job of understanding how significant that is. And so that's the kind of work that I want to do. And I also think that it's really important to kind of generate more public awareness of why that is so critical, because it impacts our lives in so many different ways.
Thank you so much for your time with us. I really appreciate it. It's been really good talking to you. Thank you.
No, thank you. Thank you.
Thanks, Katelyn. Lovely meeting you.
Great to meet you too. Pleasure.
Bye. Thank you to everybody for listening to us. We'll put up links on our Twitter account, which is at Anti-Waffle Pod. We'd love to hear from you. If you'd like to get in contact, please do email us at antiwafflepodcast@gmail.com. Thank you so much. Bye.
Bye.